I was reading your curriculum vitae tonight, and I was very impressed. You are a remarkable person, and King's College is a remarkable reputation. A lot of people who come to our centre speak very highly of King's College. I know you're a centre of excellence. You are really recognised for your non-motor and your non-motor symptom specialization. What exactly is your specialization? What do you most enjoy working with? What aspects of Parkinson's most draw your attention?
Yeah, you've asked me a really good question. So I think it's really good to clarify that when I started out in the field of Parkinson's, that's going back into the late 90s, um, people, when they thought about Parkinson's, usually referred to as a condition where you have stiffness, tremor,
Have you turned your
difficult.
video off, Doctor?
I haven't, but somehow it's not
Ah,
very quickly. So yeah, I think the reason is you asked is that I was struck by the number of people with Parkinson's I was saying whose main problem might have been pain, difficulty at night, difficulty with sleep, depression, anxiety, some people with memory issues, some people with, bladder problems, some people with dribbling of saliva,
and so it
and
goes on.
nothing was being done for it. And neurologists don't do anything about it. They didn't know about it, or if they knew, they didn't know what to do with it. So it's an area that I got more and more interested in and developed that field. So, the measurements of all the non-movement part of Parkinson's all stems back to our work in the late 90s and early 2000s. And I'm happy to say that it is now established part of Parkinson's management and is what people now regularly look at in the clinic. I wouldn't say regularly, but people should and do. So that in a nutshell, that's what is my area of interest.
Right. Interesting. I know that Daniele Volpi is the Fresco Institute. We work with him a little bit with our neurophysiotherapy side with Becky Farley. I know he's working with Bas Bloom on a ParkNet type idea here in Italy. And I know he worked on Irish dancing, and I had an argument with him one day. I told him that the Irish dancing wasn't what made Parkinson better, it was the Guinness that they had with the Irish dancing. Now, I know you had a lot of work done with English ballet. Sally Bromley, the president of the Old Oxford Association, was talking about you. And I think the ballet, I don't think you're going to contribute a drink to that. So it must be the ballet that's working. How did you get into that? And what results did you get from that?
So yeah, let me clarify that. I mean, ballet is an exemplar. In other words, it's a form of dancing that activates your brain and physical activity. And that's any form of dance that does that will have that beneficial effect. But what we showed for the first time is that by using that dance technology, people who underwent specific ballet classes with ballet instructors showed quite a marked improvement in their motor scores, movements scores, depression, anxiety, and sleep patterns. And this shows the power of physical activity using mental function, which can give you more dopamine in the brain than levodopa tablets. And our neurology colleagues and many others have ignored that for many, many years because that evidence has been in animal models for many years. And Bas Bloom has sort of developed
Of
his
course.
ParkNet service, which is only relevant perhaps in Netherlands. Many other countries can't follow that. But broadly, if you take a little bit of physical exercise every day, and that doesn't have to be running around like crazy in a gym, and do short bouts of exercise, what suits you, which might be a bit of dancing, maybe a bit of walking, swimming, whatever, going upstairs, downstairs, all of that activates the dopamine cells and the neurons and produces dopamine in the same, almost the same sort of level that you get from your Cinemet, your Matterport, your Stolivo, whatever. But we've
No.
absolutely ignored that. So my hope is that we've just now published our dashboard that every neurologist, every nurse specialist who deals with Parkinson's, and if they call themselves a Parkinson's expert, they should prescribe physical exercise as part of their treatment strategy. And this needs to be done right from the beginning when the diagnosis is made till quite advanced stages of the Parkinson. And it, as I said, it needs to be bespoke exercise. Now, ballet is okay for some people, but may not be okay for others. It doesn't have to be ballet. You can do whatever you want as long as it's a physical exercise.
Mm.
And it doesn't have to be also exercise. I prefer the term activity rather than exercise.
Right.
Physical activity. And now it seems like the minimum limit you need to do is 150 minutes a week, 150 minutes a week. If you did that, which is approximately 30 minutes a day for 5 days a week, you've hit that dopamine threshold in the brain. I have patients who have been recently diagnosed with Parkinson's who I've maintained on exercise and rasagiline now for about 4 years. They haven't needed levodopa treatment.
Mm.
So it depends how you get it, but it's very important that that is now told to the patients right from the beginning. And many of my colleagues still don't do it.
What about people who are more advanced with Parkinson's?
Yeah, you
Can
have to
you work
find
with
a
them?
way. You have to find a way. Of course, things get more complicated when you are in a more advanced stage of Parkinson because you have many neurological systems, neurochemicals that are affected, not just dopamine, acetylcholine, noradrenaline, serotonin. They're all involved. So the role of exercise, perhaps, or physical activity is really quite paramount in the earlier stages of Parkinson. When you're more advanced, it still has a role because it helps with your balance, it helps with your turning, it helps with your confidence, it helps with your fear of falling. And one
Mm.
simple exercise that is incredibly useful here is to put some horizontal strips on the floor and just step over them for about 5 minutes a day. You can
Mm.
see it in YouTube. There are very nice YouTube videos on cueing for Parkinson. And if you
Mm.
have a metronome with that, that gives you auditory clue, that helps it even more. And that is often a very effective treatment for freezing.
Mm.
People who freeze in front of door frames, people who freeze when there's a lot of, structures in front of them. And tablets don't help freezing, to be honest. But this exercise, which I call train the brain, does because it activates your cholinergic system of the brain, which is what is involved in walking. It's not dopaminergic, it's cholinergic. And
Okay.
rivastigmine is another treatment that can help it. So you can see, even in a more advanced stage, physical activity has a role, but whoever is prescribing it needs to know what they're talking about.
True. Um, just before we open this to everyone, let me just once again say how honored we are to have you with us, Professor Chowdhury. You are a pillar, of course, in the Parkinson world, along with Bass and Michael Oken and other such people.
Thank you. Thank you. Yeah.
You have
Doing
been
well.
written and you've co-authored many books and you've done a lot of research, I noticed. And a lot of that work has brought your centre to be probably the leading centre in the United Kingdom. That's me saying that. That's not you blowing your own trumpet. You can do that anyhow in your own band. Um, I can, at this stage, open it up to anybody else who wants to ask a question. Good evening, Parkinson Europe.
Good evening. This is Parkinson's Europe calling.
Hi.
Welcome to the Irish jury. Great to see you again, and thank you for
I'm
organising.
sorry, my video is not working, but that's a good thing. Maybe you don't want to really, it's not a particularly pleasant sight, so it's okay.
My lighting isn't working, which is even better. So, but I'm just very grateful that I'm here because I've already, in the brief few minutes we've been here, I've learned more in the last 11 minutes than I have in the last 11 years, nearly. I'm so grateful to hear you say that movement, whatever movement it may be, dancing, standing on your head, doing the Olympic, um, whatever, is all good for you. And I'm also so grateful to you. This is the first time I've heard it from anybody with some serious clout. I'm also so thrilled to hear you say that exercise, well, not exercise, movement must be prescribed, just like cinema is prescribed and
Correct.
Azilect. Everything must be prescribed.
Correct.
I've loads of questions for you, but I'll start with a simple one. When are we going to get unanimity and conformity within your echelons? That, yes,
You
you
know,
have opinion.
that's a really, really good question. And I also do a lot of work with this group called Movers and Shakers,
Right.
and they have asked me the same question. I have to say I'm quite pessimistic about it, which is not a good thing for our people with Parkinson's,
No.
but because there are many different other interests operating there. Um, and I think a combined view is very important, but I think the combined view really needs to come from yourselves. I'm firmly of the view that in future, maybe in a few years' time, and I'm working quite hard on it through this dashboard with patients, that we should take away the control of managing Parkinson's from this very traditional concept of, neurologists or geriatricians or nurse specialists telling you what to do, to yourselves, so that you as a person with Parkinson know that these are the things that affects you, and you demand treatment for that.
Well, I certainly can tell you that the last 2 weeks I've had a pretty rough time. I've had surgery for sciatic nerve and all that kind of stuff in my back. But the worst part of being in hospital over the last 2 weeks was the battle I had to hang on to my own Parkinson's medication and my own prescription and be able to take that. And that was, believe it or not, that was in the hospital where I go every year for my assessment. I won't say what it is because some people don't know where it is. But eventually, the guys came into me, the neurological consultants came into me and said, "Look, Gary, you know more about this than we do, so you just kind of prescribe your own or control your own medication." But everybody has a battle, and that's another question I have. I don't know who's going to answer this question, but we carry on our lives as much as we can. We live as best we can. We do whatever we can. We do what we're told, mostly. What we're
Well,
told.
you should not be do what you're told. I think.
But
I
I
think.
think we're going to be told, we're going to do what we're told when we have experiences like I had last week. People actually physically taking the medication off you, medication you need at certain times every day. None of the guys that I was dealing with, none of the ward sister, senior manager on the floor, none of them knew anything about Parkinson's being a specially regulated time-based therapy. And I find that really, in this day and age, I find that shocking. I mean, communication has never been easier, and yet we're getting the basics. It's baby stuff, you know?
I
Sorry.
agree. I think there is a lot of work to be done, but one of the things that and I will upload this for you, is that it's important that there are some things that we now know that you can do yourself. You don't really need, months to wait for a nurse or a doctor to tell you that. One simple thing I'm shocked to hear over and over again is if you're taking levodopa of any form, Madopar, Cinemet, Stalevo, whatever, one of the fundamental first things the doctor or the nurse should tell you is that it should not be, once you've taken the drug, it should be taken in an empty stomach, and you should never, or ideally, as little as possible, take any milk products with it. So in other words, if you take your niacinamide or your Madopar, for at least 40 minutes after you've taken it, you should not have any dairy, because dairy flattens the absorption of these tablets. It's a simple advice. But often, if you go and say, doctor, my tablet's not working anymore. In the afternoon, I take it, but it doesn't seem to work. And they'll say, oh, well, let's have an increased dose. No. Find out if you're having a coffee or tea, or if you're having a bit of a cheese, or cafe latte or whatever. And if you are, that is what's causing the problem. It's well
Before you work it
established.
out myself.
And I don't know why this is never told.
Okay. Can I just mention that Mark Holt Rogers has had his hand up a couple of times? So would you like to ask a question, Mark?
I know Mark pretty well, yeah.
And you? You worked it out.
Hello. Hi, Alex.
Hi,
It's Rebecca from the Isle of Wight.
hi.
Hello. I just had a question to ask, a little bit around the dashboard, and I think it ties a few things together potentially. It was certainly in my head anyway, around the NICE guidelines. Because does this make a change more likely to happen? Because I think the NICE guidelines haven't been changed. I think I'm right in saying since 2017. So
Correct.
would that make a difference with some of the movers and shakers and the charter the Parky charter they're coming up with, some of the changes that they want? Is this something, and the dashboard you're talking about, is this something that's likely to come into the NICE guidelines at some point, and would that make a difference? I'm sorry if I'm ignorant and that's not related.
No. It's an excellent question. And that's exactly what we are working on, whether or not, you see, we or I have limited powers. Perhaps I would like to say that on behalf of all of you, that might be a bit presumptuous, but that's what I think I'm doing. But it really when it's articulated through a patient voice, then people listen. So I've now got some influential people. You see, that's very interesting. I'm again talking from a very UK perspective. I know there might be others here, but in the House of Lords in the UK, there's representation for epilepsy, there's representation for dementia, there's representation from stroke, nobody for Parkinson. So I tried to influence some people to get in there to talk about Parkinson, because it's a massive issue given the rising numbers and the fact that with modern treatment, most people with Parkinson live a normal lifespan. So I'm hoping these recommendations of mainly diet with levodopa, probiotic use, another big area of interest, particularly probiotics such as Simprove, prescribing of physical activity or exercise, dance therapy, all of this should be included in a modern guideline for Parkinson, and certainly in the NICE, which is long overdue. And you're absolutely right. It's 2017. They did a little bit of an update, I think in 2019, but it really needs to be updated and should be reflecting these advances, because, it's increasingly apparent that we have long ignored the non-dopamine strategies which anybody can use. You don't need to wait 6 months from a neurologist to tell you should do 150 minutes of exercise a week. You should have your levodopa. Don't take your dairy with it. You should have a Helicobacter pylori bacteria check. You should have, walk regularly with a strip, on the floor for 5 minutes, etc. these are simple, basic things that every person with Parkinson's should be told. And I think a guideline that would come out from NICE or general unified guidelines from learned societies would do it, but it has to be driven through the patients, I'm afraid.
Okay.
I mean, if we jump up and down and say it, or if I jump up and down and say it, many of my colleagues will say, "Oh, he's just trying to publish a paper." So, there are issues around there as well.
We are having one or two pushes from outside on security issues. The screen is doing one or two weird things. But if I can go to Diane Hull, that would be lovely. If you could take away your mute.
Hello.
Hi.
I couldn't find my yellow hand. I've had Parkinson's for 20 years and I didn't know about the milk. I regularly have milk products and coffee, and I can't believe that I didn't know that. There must be so many other things that I don't know.
That is a big question.
Well, you're not the only one, but I'm sorry to hear that, to be honest, because it's a fact that's pretty well established. It's
Yeah. So I'm wondering what else I don't know. I do believe in positivity.
Did you say you had Parkinson's for 20 years?
Yes.
I mean, that's positive as well, isn't it? That, you're doing well, you're there for 20 years of Parkinson, and, it shows that with modern therapies, I believe everybody with Parkinson has a normal lifespan. But even when I was training, that wasn't the case. It was thought that it shortens your lifespan considerably, but that's absolutely not true. But now I think we know also that's maybe not so much the diet thing, but there are other things such as physical exercise. And the other thing I didn't mention, sleep. Now we know 6 to 8 hours of sleep a day, and it doesn't have to be in one go. It can be, you have an afternoon nap for 1 hour or half an hour. So as long as it adds up to 6 to 8 hours a day, it has an enormous effect on overall progression of Parkinson. We now know it reduces one's rates of dementia. It activates a system called the glymphatic system in the brain that gets rid of a protein called amyloid, which we know can cause cognitive or memory issues. So, there are these simple measures like 6 to 8 hours of sleep a day. It should be prescribed. Again, it's not just, have a good sleep. No, it should be prescribed. Try and get 6 to 8 hours. Okay, I can't sleep for 6 hours, doc. Fine. Have an afternoon nap. Very good for you. Because even a half an hour good afternoon nap replaces more dopamine than sometimes taking a tablet. But these things traditionally we have not paid enough attention to, and that's our fault. But now the evidence is there. It should be followed up, and you're right. It should be incorporated in different guidelines, and I hope that comes very soon.
Well, you made a lot of logical sense, and you're saying a lot of things which I think some people with Parkinson already know. And maybe we can have a voice in this as well. Certainly the centre in Italy does cover all of these issues too. And I wish more people did. I wish more neurologists did too. I noticed that Gary had his hand up again. And also, have we got back any of our previous speakers? Bob. Go for it, Bob.
No,
Audio's not going.
tell him to write them in the chat.
I see Mark has a hand up.
Yeah, sorry, Bob. Mark?
I'm back. Can you hear me? Can you hear me?
Yeah.
Yeah, I can hear you.
Good. First of all, pleasure shadowing my doctor, 14 years. So thank you, Tim. Still here. I've been always especially for my life. Exercise is my biggest one thing. My Professor Chaudhuri told me from the first day, I exercise every day, and I play golf, I do Thai boxing, I have a gym at home, I work every day, stretch every day. Exercise is my number one thing. It's vital. I've done it 14 years now. I won't stop ever. It's going right. So Professor Chaudhuri is fantastic that way. Superb. I've worked in well-being for 21 years in my own business. I'm a well-being coach. And what really, I think everything you say today is fantastic, because it's really works. Good gut health, sleep, exercise, fantastic. So I really pleased to be on this call. Thank you, Chaudhuri. It's been brilliant. Thank you.
Thank you, Mark.
Yeah. Can Bob, you write into the chat your question, because we're having trouble getting your message through. So you can
By
write.
the way, I have uploaded the dashboard and the dance paper on the email you sent me.
Great. Fantastic. Well, we'll circulate that to everyone afterwards.
Just one quick note on that, Alex. Just sorry to interrupt you. Just a quick note on the publication. The Irish set dancing study is published in the British Medical Journal. Has been for about the last 10 years, I think. But just to let you know, we did our homework.
Well, Daniel there was telling me about that, and he's very proud of that.
Yeah.
It's just one aspect of the
Yes, of course.
Parkinson equation. I wanted to ask you, Professor, I noticed in your resume you mentioned dystonia. Dystonia we come across quite often, and it's quite a large impediment when it's in a acute stage. Is there any way in which dystonia had a relationship with levodopa or any other drug which you can suggest?
Yes, it does. So dystonia in the context, I mean, dystonia can be there without Parkinson, of course, it's a condition in its own right. But dystonia, for people who might not be familiar with it, is abnormal posturing. And perhaps the one that we see most in the context of Parkinson is when the drug is wearing off, or the dopamine, the levodopa preparation, either Sinemet, Madopar, Stalevo, whatever, is not, I mean, you're in need for the next dose. And often it is manifest as the toes curling up, or, fingers going into a bit of a spasm. Usually it can be associated with cramps or pain, or sometimes we see one side of the body being held in a different posture. I often have people who come to me saying their first sign of their Parkinson was when they're dragging their leg, or perhaps the arm was not moving properly. And when you examine, the arm is held in a slightly odd posture. That's dystonia. So in the context of Parkinson, it's really a sign that there is dopamine deficiency, and that needs to be corrected. So off-related dystonia is very, very common, and that's usually in the toes, in the fingers, sometimes in the neck. But in addition, you can also get dystonia. It's quite common in people who develop the condition in an early stage, early years, probably below the ages of 50 or 60. So there is, and then finally, you can get dystonia as a side effect of levodopa. If you have excessive levodopa, you have these abnormal movements, which we call dyskinesias, which you know. But in some people, dyskinesia can be associated with the feet turning inwards, or the arm going into a sort of a spasm, and that's often dystonia as well. So it's an interesting phenomenon because it can both be a sign of deficiency. At the same time, it could be also related to over replacement of levodopa. So it's a bit of both.
Thank you. Crystal, Kafka, can you take your mute off?
Ta-da! Hello. Thank you so much for doing this. This is really wonderful. I wonder if we could go back a topic to exercise. And you said no subject was off limits, right? So this might be a little strange, but what I'm wondering is when we are in situations where we can't exercise, for some reason we have to stay in bed for extended periods of time, or we're at the hospital, whatever. Is there anything to show that the studies that they, I'm going to go into another thing, the studies that they showed that when people imagined they were exercising, that their brains lit up as if they were exercising? Is there any value to using that idea?
I know what you're saying is it's like mental exercising, whether that's manifested as the equivalent of the physical not really, to my knowledge. Of course, we have to remember that the exercise or physical activity driven benefits are related to the movement of the muscles and the actual exercising activity is itself. So just by mental activation, if you're not able to do anything at that period, I think it's unlikely to be able to mimic that. That I would have thought that would be my idea, but I'm not sure about whether that specific area has been looked at in detail.
Sure. So I guess the only avenue that we have really is to find the exercises that you can do.
Yeah.
While you're laid up.
Exactly right. And it's worth remembering that, as I said, that it's not about going, it's not about okay, there is some data suggesting high intensity exercise in short bursts might be actually quite beneficial in Parkinson's. People who can do that, fine. But those who can't, any form of exercise seems to be of benefit as long as it sort of, counts up to a reasonable amount. Now, if you're in a situation you can't really, you're bedbound or whatever for whatever reason, then yes, moving around in the bed with some structured physical activity, which a physiotherapist can advise, should surely be of benefit, I would have thought.
I phone Becca.
Hi, sorry, back to me.
Yeah, back to you.
Thank you. Just going back, sorry, to go back to, I'm a physio actually. I'm not I'm not someone with Parkinson's, but I'm particularly interested in, especially the kind of first year with someone and someone's kind of diagnosed this year and getting people into really good activity, exercise behaviours at the beginning. And when I started looking into it, that's what I was saying about the NICE guidelines, that a lot of stuff is around suggest, not kind of doesn't actually mean that you actually have to do anything about it. You mentioned earlier about changing guidelines. The easiest way of doing that is for people with Parkinson's to get involved. And obviously movers and shakers are trying to do quite a lot. I would imagine, I could be speaking out of turn, but I would imagine there would be a lot of people here who would do a lot to help out if there's some. So when you say it needs to be people with Parkinson's who needs to help guide this, how can they help?
Well, I think it's lobbying, as you already alluded to, lobbying your own group, so as to then it goes to the central foremost charities, because they are officially the spokesperson, aren't they? So I would have thought, for instance, in the UK, Parkinson's UK, or Cure Parkinson's Trust, although they're more focused on early stage of Parkinson's and molecules for cure. They are the ones who then need to lobby the central policy makers. I think that's the only way I can think about it, to be honest, because there's enough papers and evidence base there. It's not about producing more research. There's enough research.
Yeah.
With more research. It's not about, doing another trial. We don't need another trial. So I think it's really just being very voluble about it amongst whoever you feel is influential. And that could be at a local level, I don't know, through your local MP or whatever, but also that the message needs to get back to the central patient charities, that this is what they need to, then, they will have a voice. They are funded through taxpayers' money. They are working for our people with Parkinson, and they need to sort of make the concept more real so that the policymakers can't ignore it. And that's how, for instance, many treatment of MS and cancer, etc., have come into being. It's through that sort of lobbying. So I think that would be the way forward, I would have thought.
Okay, thank you. Yeah, I mean, I could see a lot of people signed the Sparky Park, the Movers and Shakers Parky Charter. I could see that, but and I know they went to government, they went to Downing Street with it. I kind of was hoping that might have made more of a change.
Yeah, you're right. I mean, of course, then there was a government change. So, there was, they went, I think, with the previous government, I can't remember. So again, it should not be dependent on the government, really. It's a generic issue. That's independence of politics, but that's how I guess things run. So maybe that needs to be reactivated again.
Dag, could you actually say your question you put into chat and say it out loud? Because I know you and I know exactly your experience. You are a remarkable man. And this is an interesting question.
Okay, yes, you're asking me to speak up.
Thank you. God bless you.
I'm a mechanical engineer by background and training and way of thinking. I've been involved with psychology and neurology for going on 40 years, which makes me one heck of a skeptic. And when my wife was diagnosed with Parkinson's 6 years ago, I turned toward looking into what causes Parkinson's, reading books, what can you do about it? And I find that the I live in California, the American medical system emphasizes treatment of symptoms, and physicians are poorly educated. Wait a second. The medical school curriculum is huge, but there's not much room in the medical school curriculum for biochemistry. In fact, my geriatrician said when I brought this up that, my undergraduate degree was in chemistry. Biochemistry is taught in medical school in the second semester, and the students' eyes glaze over. So as a consequence, your average physician knows very little about the biochemistry and little about metabolism and little about nutrition. And I have come to believe that the root cause of most of these degenerative diseases is our culture's reliance upon plant foods, carbohydrates. And my wife and I switched quickly and somewhat recklessly, some of our relatives thought, towards first keto and then 2 years later a carnivore lifestyle. I believe we did very well given Parkinson's. Unfortunately, my wife also in her 30s and 40s worshipped the sun as a transplant from Sweden to California. And so she passed on a year ago from melanoma, stage 4 cancer. No complaint. She was happy to get rid of all the pain that was associated with Parkinson's. Our culture promotes degenerative disease of many flavors. And if you look at my last name in this little screen here and spell it correctly and add a .com, you'll find everything I've learned and all my opinions and summaries I've put together.
Okay, do you have a question from all of this research? Would you like the professor to comment on your protein-rich diet?
Were you asking me a question?
Yeah, I want to know whether you want to ask a question to the professor.
Oh, why? The question would be, why is there no critique of our populations, our cultures, dietary habits? I do know, and Alex, you recommended to me that I read this book, Ending Parkinson's Disease. I found it had no reference to nutrition. It did have a reference to Mediterranean, and I am not impressed with the evidence that shows that the Mediterranean diet is a little less bad than whatever the American Western diet is.
So your question is, what would the professor's opinion be about diet?
Yes.
Okay.
Well, thank you very much. Yeah, I take your point. I mean, it's a very controversial area. I completely accept and respect your views, but there are, of course, many others who disagree with that. And again, there's been roles of ketogenic diet, but similarly, claims have been made about many other sorts of diet. You mentioned Mediterranean diet. To be honest, there have been no very clear what we call level 1 evidence to support one or the other. What we can say now that with physical activity we have that now recently with probiotic therapy. We now have that also perhaps coming up, not yet published fully, with dance and other physical activity-based therapies. I think nutrition needs to have studies such as that, which can then establish into the mainstream. But I'm aware that many people have their own beliefs. I mean, like you mentioned, the organophosphorus, tetrachloroethylene, etc. But there is a very recent review paper in Movement Disorders Journal from a very respected group saying that they didn't find enough evidence to say that this is entirely causative. So, there's views on both sides. So I'm not too, when people come to me and say, I'm taking this diet and this will get rid of my Parkinson or make me feel better. If it does, and if it's not doing your metabolic system any harm, I don't have any specific problem with that. From my perspective, the diet role remains is its interaction with oral drugs, particularly levodopa, and I've mentioned the role of dairy and protein that's well established by blood levels of levodopa. So I think there's very little evidence to refute that. But also there is evidence that red vegetables, berries, may well have some sort of a neuroprotective property. So if you have your diet rich in that, and very recent data also shows that very high ingestion of red meat predisposes one to high rates of neurodegeneration by default. That has an effect on Parkinson's, so perhaps better avoided. It's that sort of generic advice, which is good for healthy living anyway. So that's the sort of area we're looking at now. There are many, many people working on diet, of course, and nutrition. Laurie Mishley, for instance, from Seattle, and several others. But I think the area still needs quite a bit of concentrated work, in my view. But I see where you're coming from, and of course, I'm very interested to hear your perspective on it.
Thank you, Dag. Gary, I know, had lots of questions, so I'm going to allow him one more question tonight. And Gary, go ahead.
I'll be very brief. This has been a really fantastic sharing of information and experience. I really appreciate everybody what they've said. What I would say is the big question, and it's about possibility thinking. And directly to you, Dr. Chaudhuri, what do you think it's going to take to turn all the research and all the experience and all the knowledge that's even on this particular website? What do you think it's going to take to get over the line and get that Parkinson's final cure that we're all looking for? And I think alluded to that, in line with that, any interaction with the likes of the movers and the shakers or whoever are the famous people in the different countries represented here, the people who would know, because I think we need to get them spun up on what's going on with Parkinson's disease. But can you tell me what do you believe it would take to get a cure for Parkinson's? Even something like identifying how to stop Parkinson's continuing. What do you think it's going to take?
I think you've asked a fantastic question, and I'll give you my take on it. It's a very difficult question to address, obviously. But look, I think we've been trying to cure Parkinson for the last 40 or 50 years. And for instance, neuroprotection, trials, billions have been spent, 38 different molecules have been tried, and they've all failed. And I think the evidence is very clear on our face, is that Parkinson is not just a single condition. It varies. It's variable amongst all the people that are coming to this webinar today. Some people might have more tremor, some might have more stiffness, some may not have a tremor at all. Some may have had the condition in their 30s, 40s, 50s. Some may have had it starting at 80s. Some may have problems with their balance, others not. The condition progresses very differently in very different people. There are racial variations. There are variations between sexes. So we need to think about Parkinson as a medley of symptoms, as a syndrome. And we wrote about that in 2017, and others have done that before us. It's only last year that the society got together and finally recognized, oh, it's not a disease, it's a syndrome. Well, actually, Dr. Parkinson did not call it a disease. He called it a shaking palsy, which was wrong, of course, because it's not just shaking and it's not a palsy, but still, he did not call it a disease. And I think in terms of cure, there needs to be a combined approach. There needs to be an approach that looks at the drug side of things, the pipeline, and combined with that, it is to bring in these strategies that we've talked about today and make it what we call a multi-omic approach, a multi-prong approach, like we do in some other condition. And to be honest, again, I would not think so much about a cure. I would think about, for instance, if I developed Parkinson, if I went to my doctor and if the doctor told me, look, you're in this state, but I have something that will keep you in this state, exactly this state, 5 or 10 years later, that was a great development. Now, that's what we need to achieve, strive for. But to do that, we need drugs plus non-drug therapy together. And that, based on that, develop trials, not just a single molecule approach, which I think is a tunnel vision. A single molecule will address only one mechanism for Parkinson. But we know that the condition has many different mechanisms operating. And that's what we need to try and address. And I think when we start doing that, and I think increasingly people are waking up to this, I think it will happen.
Okay. I think Bas Bloom said it very well recently. He said, no medicines are going to slow down Parkinson's as they are today. The only thing that will slow down or will have an effect on your Parkinson's is regular exercise, which is where we started this evening and we're coming back to again. And that is, I think, a theme which runs through pretty much every type of Parkinson's. And I know Michel Hu has done a lot of work with the Oxford Parkinson Research Centre on the types of Parkinson's. And it's very interesting to see that exercise is the one thing which remains constant. It seems to be an element which is fundamental in dealing with Parkinson's. Has anyone else got any other questions whilst we've got such an illustrious speaker on with us? No, all scared off by him. Anyone?
Yeah, there's Mark Holt is trying to say something there.
Hi, Mark.
Hi, back again. I've got a question for you. Mental health. Mental health is a massive issue.
Brilliant.
For symptoms, but also for the effects of it, for the effects. The effects of Parkinson's for my family, myself, all the way through my immediate family is huge. So I think mental health is something we're not talking about. So my symptoms have affected much by stress. I think if we can get more stress management, knowledge about stress, would be fantastic.
Yeah.
I didn't get
Yeah.
the question, Mark. Yeah, I mean, I got mental health,
Yeah,
which
you're
of
saying,
course is a massive issue. I completely agree. And I mentioned in the beginning, didn't I, about depression and anxiety in particular, and apathy when you lose interest in things that were of interest to you are big issues in Parkinson. It changes personality, it changes, your domestic, physical, other sorts of interactions.
Mark,
And
did you have a specific question you wanted to ask?
just wondering what support that Parkinson's people should have mental health wise and diagnosed.
Yeah, definitely.
Did you hear, Professor?
yeah, I think support-wise, again, I'm afraid it boils down to resources. I mean, ideally, yes, support needs to be there, and I've long championed the role of multidisciplinary treatment in Parkinson. It just boils down to what we've been talking about all evening about the non-pharmacological measures, the huge role of skilled physiotherapy in Parkinson from very early stage, the big role of speech and language therapists, talks on voice therapy, because all of these, if properly done in early stages, have a role on mental health. We showed through our dance therapy, for instance, it has a very clear role on reducing anxiety and depression and social isolation. So all of these things are interlinked, and it really depends on resource being used skillfully with the relevant expertise. But that then brings to the whole infrastructure of how healthcare is being delivered and, where you're going to get the resource from, etc. So that's beyond my remit, to be honest.
Well, thank you for that, Professor. You've just given a good advertisement for the European Parkinson Therapy Centre, which does believe very strongly that it's not just the medicines, it's a whole lifestyle, it's a whole way you look at your Parkinson's and the way you exercise and live with Parkinson's. It's much more complicated than some people can explain. And I think that message has come across clearly tonight. What do you think is the most likely area of innovation in the medical field in the near future? I'm talking about stem cells or
Yeah,
other.
I think there would be developments of pluripotent stem cells. In other words, stem cells that divide into various different neurochemicals and then try and address the different types of deficiencies that occur in Parkinson. Because as I said before, one size doesn't fit all. So, and then in addition to that, the different non-pharmacological measures that are being developed, there is the vestibular stimulation that's being developed, which is earphones giving you heat and cold in the ears, which stimulates the brainstem, which seems to have a good effect, bright light therapy for sleep. There are quite a lot of interesting developments coming up, specific forms of deep brain stimulation, ultrasound therapy, etc. So there are therapies, symptomatic therapy, maybe not many of them address progression, but more symptom control. But I think really we need something quite robust to really try and address the progression of Parkinson. That's still lacking, and I'm hopeful that that's something we will be seeing quite a lot of advance in the next few years.
Yeah, interesting. And does anyone have any last minute questions? We're literally into the final minute. I can hear a voice.
Brilliant, Ethan.
Do you hear me?
I can.
Okay. I would like to ask how does one know that that you are getting the optimal dose of drugs? In other words, do you combine a test, a diagnostic test, or it's only a trial and error?
Which test are we talking of again? Sorry, I didn't get that.
Well, it could be of a dopamine, or I'm not suggesting a test. I'm just asking whether, the doctor says, okay, if you still have tremor, take another one a day or split it or
Oh.
whatever, or do you take a test, and if you don't, why? What is the reason other than finance, expensive?
Yeah, so it's again, another real issue in Parkinson is this, what you've just highlighted, is what I call the granular monitoring of dopamine. I mean, you really can't do that. You can do a DAT scan, but that gives an approximate measure of a dopamine transporter in the brain. It doesn't really help you with monitoring. I tend to use a wearable sensor called PKG. That's like having, wearing it for 7 days at home, and it gives you a recording. It's a bit like if you had blood pressure problems, your doctor gives you a 7 days blood pressure monitoring at home, or if you had diabetes, you get monitored at home. It is the same for PKG, but this is approximate. But their low levels would suggest that we need to increase your dopamine intake. High levels would suggest that you need to monitor the dyskinesias, etc. So you can support your clinical observation, but more or less, that whole concept of when to increase, when to lower, still remains very much clinical. That's why management of Parkinson is so complex and so difficult.
Yeah. Michael, any
Yeah.
comments?
I heard it. It's a try and error, right? But the bottom line is difficult to monitor, and you just have to try and see what works best for you, right?
Yeah, in a way, but you can monitor. There are good validated wearable sensors now. And again, I use it and I find it very useful because
What's
it
the
tells
name you
you.
use, Professor?
The one I use called PKG, Parkinson's kinetograph. It's widely available. It's been used since 2014. But, and it gives you information. It gives you 7 days information in a graph, which you can't get in a 25 minutes consultation or 20 minutes. But then you need to know how to interpret it and how to use it. That's the most important thing. If you don't have access to it, or if you can't use it, then you have to rely on, clinical observation.
So where do you find it?
It depends on where you are, to be honest. It depends on whether the resources are there. But you can look up PKG. You can just go to Google and put PKG.
PKG, and three
Yeah.
letters, PKG. You say it's Parkinson?
Kinetograph, PKG. Watch. It's just a watch. That's all.
We'll close the evening here.
I just want to say thank you for the most informative 1 hour and 2 minutes that I've had in a long, long time. I'm so grateful and I really appreciate your time.
Thank you very much.